everyone. Welcome to today's Lunch and Learn from Data to Impact, how Peel Region leverages a core public health data source. Thank you for taking the time to be here today. We're excited to have members of Bourne and Peel Region joining us today and look forward to a great session together. My name is Mariah Maddock, and my role at Bourne is Strategic Partnership and Network Coordinator. I will be hosting today's Lunch and Learn. I am joined by my colleague Tammy Kupfer, Communications Specialist, who will be managing the chat box and other items behind the scenes today. Today, Peel Public Health's Population Health Assessment Team will share their history of engagement with Bourne, highlight public-facing products and internal applications of Bourne data, and outline opportunities to strengthen public health access. This session aims to show how Bourne supports public health work across Ontario and spark ideas for future enhancements. We'll close with a Q&A to continue the conversation. And before we begin today's Lunch and Learn, we acknowledge that Bourne, Ontario, hosted at CHEO, is located on the traditional, ancestral, and unceded territory of the Algonquin Anishinaabe Nation. We honor the enduring presence of Indigenous peoples and their long-standing stewardship of these lands. Today, as we discuss how data informs public health, we recognize that Indigenous communities have been knowledge keepers since time immemorial, shaping understandings of health, family, and community that guide us to guide us today. In this work, we are also guided by Bourne's commitment to Indigenous data sovereignty, which emphasizes respectful, responsible, and self-determined approaches to the collection and use of Indigenous data. We also acknowledge that some colleagues today are joining from territories across Ontario, home to diverse First Nations, Inuit, and Métis peoples. We invite you to reflect on the land you are on and the Indigenous peoples who care for it. Today's Lunch and Learn is being recorded. A recording will be shared with participants when it is available. And I'm now pleased to introduce our speakers for today. Our first speaker is Natalie Causarano. Natalie has been a member of the Peel Public Health Population Health Assessment Team since May 2016. She has held the roles of health analyst, epidemiologist, and supervisor, working with a variety of public health data sets, including Bourne. Before joining Peel Public Health, Natalie worked in clinical research at the University Health Network. Her experience includes data collection, management, analysis, and reporting, as well as project management. And our next speaker is Gabriella Christopher. Gabriella is an epidemiologist with Peel Public Health on the Population Health Assessment Team. Since November of 2025, she has supported the Family Health Division, which includes working with Bourne. Previously, she supported areas related to chronic disease and injury prevention since March 2024. Before joining Peel Public Health, Gabriella worked in epidemiological research at the Canadian Institute for Health Information. Her expertise includes the development and application of epidemiological methods, as well as the management, analysis, and interpretation of survey and administrative health data. Thank you both for being here today. And for the Q&A portion of today, we're also joined by Greg Kubita, manager of the Population Health Assessment Team with Peel Region. And before we get started today, here's a very quick overview of the team's platform. You're welcome to turn your camera on if you'd like to. Everyone is automatically muted when you join today. At any time, you can feel free to submit questions using the Q&A feature, and we encourage you to do so throughout the Lunch and Learn. The presenters will address your questions following their presentation. And if you'd like to ask a question using your microphone today, please use the raise hand function and we'll be able to unmute you. We'll take questions from the raised hands first. And with that said, let's get started. I'll now turn it over to you, Natalie and Gabriella.
Thanks so much, Mariah, for the warm introduction. Just maybe if I can just get a check in the chat that everyone can hear me. Maybe just one from one person. Perfect. Thumbs up. Thank you so much. Great. So we're very excited to share with you today how Peel Public Health uses born data. So just before we dive in, we just wanted to set the scene at Peel Region. So we're a very geographically large public health unit in the Greater Toronto and Hamilton area. And so we're bordered by 5 health units or regions, which includes Toronto, York, Simcoe, Muskoka, Wellington, Dufferin, Guelph, and Halton. And within our area, within Peel Region, we have 3 hospitals, 2 are in Mississauga and 1 in Brampton. However, almost 1/3 of the births to Peel Region residents actually occurred at non-Peel hospitals. And so that's just what I'm showing here in the slide, in this light blue bar. So this is important information for us to have, just as we understand who our clients are and how we're connecting with them. So as Mariah briefly mentioned, just a little bit about our agenda today. So I'll speak about Peel Public Health's history and engagement with Born. And I'm very excited to show you some of our public-facing products that use Born data, and I'll do a little bit of a live demo of one of our products. And then Gabriella will discuss some internal use cases of our family health division of when they've used Born data and the impact. And then she'll also discuss opportunities for enhancement. And then lastly, we'll have an opportunity for Q&A. So just briefly, some background on local public health in Ontario, including our mandate and our programs that support Peel residents during preconception, pregnancy, birth, childhood, and parenting. So currently there are 29 public health units or PHUs across Ontario. And each is governed by a board of health, and each unit is led by a medical officer of health or an MOH. And these boards can have differing governance structures. And so I just have a little picture here of the region of Peel. So we are a regional municipality and an upper tier municipality. So we consist of 3 municipalities, Mississauga, Brampton, and Caledon. And there, we have a subset of councillors from those municipalities, and all 3 mayors come together to form a regional council. And our regional council acts as our board of health. And Peel Public Health then delivers programs and services to Peel residents. And I mentioned we're large geographically. We also are large in population. So we serve the 2nd largest number of residents after Toronto. And we usually have around 16,000 births a year, although we just took a look at our latest born data and we have more than 17,000 in 2024. So that's exciting. So we are a large health unit. And so the mandate of Ontario public health units comes from the Provincial Health Protection and Promotion Act. And the purpose of this act is to provide for the organization and delivery of public health programs and services, the prevention of the spread of disease, and the promotion and protection of the health of the people of Ontario. And so within this act, we have the Ontario Public Health Standards, or OPHS. So just have a little picture of the document. And the OPHS identifies the minimum expectations for public health programs and services to be delivered by Ontario's 29 boards of health and public health units. And so these standards are broken into 2 sets. One is our program standards and one is our foundational standards. And our foundational standards support the program standards. And so these include health equity, effective public health practice, emergency management, and population health assessment. And so our team at Peel, myself, Gabriella, and Greg, we fulfill the work of the population health assessment standard. And in terms of programs, healthy growth and development is one of the core public health programs as outlined in the standards. And so each of these programs has a goal, outcomes, and requirements. And so the goal of the Healthy Growth and Development Program is to achieve optimal preconception, pregnancy, newborn, child, youth, parental, and family health. And the program has 8 specified outcomes. And finally, there are requirements, and one of the requirements um, is that boards of health shall collect and analyze relevant data to monitor trends over time, emerging trends, priorities, and health inequities related to healthy growth and development, and report and disseminate the data and information. And so this data requirement is embedded in each program standard. And this is in addition to the population health assessment foundational standards. So there really is a very big focus in public health on data. And we just wanted to tie that back to how important born data is to public health. And so our family health division at Peel really focuses on delivering the healthy growth and development programs. And so we have, I think, a number of family health division colleagues here with us today. So I hope I do a good job at describing their work. And so we have within our family health division 6 programs that deliver services that support children and families to build a strong foundation for lifelong health and well-being. So I just have the 6 programs there on the screen. So we have an infant feeding program. We have a multi-channel contact center where Peel residents can call in and speak with a public health nurse. We have our reproductive health program, our nutrition and physical activity program. And then I think people at Born may be familiar with Healthy Babies, Healthy Children, given your partnership with them. So that program is funded by the Ministry of Children and Youth services and then delivered by the public health units. And then we also have a research policy and planning team, which supports these programs. And then at Peel, we have our public health intelligence division. So that's where our population health assessment team falls. And so we provide centralized data and epidemiological supports to all divisions at Peel Public Health. So now that I've provided some background on local public health and our data needs, I'll share our history and engagement with Born. So there's a few organizations that started this engagement. So we have COMO, or the Council of Medical Officers of Health. So that's different medical officers of health from public health units across Ontario. And we also have an Association of Public Health Epidemiologists in Ontario, which we refer to as AFAO, which again is epidemiologists from the different health units coming together. And so in 2010, these two groups partnered to advocate for PHU access to Born Ontario data. And so Peel Public Health was and continues to have an active role and is a member at AFAO. And so those two groups came together and submitted a discussion paper to Born on this topic. And really, as a direct result, AFAO representatives were able to engage with Born to then identify a mechanism for access to Born data for relevant data elements for public health. So that was in 2010. And of course, as you know, the Born Information System launched in 2012. And then by 2014, public health units, including Peel, were able to sign data sharing agreements with Born, and we were given data access. And so just coming back to the Ontario Public Health Standards, a vital component of the data sharing agreement between Born and the public health units is the rationale for the use of Born data. And really, this comes back to the standards. So within our data sharing agreement, it states that PHUs can use Born Ontario data to facilitate and improve the provision of healthcare by demonstrating compliance with the standards. And the original agreement specifies 2 standards, reproductive health and child health. And these were from our then current 2008 standards, which were eventually incorporated into the Healthy Growth and Development Standard that I discussed previously in our now current version. Just important to note, public health units agreement with Bourne also clearly states the data cannot be used for research without further approval. So then in terms of our access, we have about 90 dimensions or variables, which are available to us through two tools. So we have our PHU standard reports. So these are four canned reports with predefined indicators of public health interest. And so I've just got their names listed there. And so we can input the desired time frame for the data and then run the report. But then we also have another tool, the Public Health Unit Analytical Reporting Tool, which for short, we refer to it as the Cube. And the Cube tool provides us with more options for analysis because the other reports are canned and therefore the indicators are not modifiable. So with the Cube, users can create customized pivot tables by selecting those dimensions or variables, and we're able to populate them with certain measures. So for example, the number of births or the number of women who gave birth. And so PHUs do not have access to individual records. We have access to aggregate data. And so we work with, at Bourne, Paula Morrison, who's as I'm sure as many of you know, is the clinical content specialist for public health and HVHC at Bourne. And so Paula helps us with access, troubleshooting, and to maintain our annual compliance with the data sharing agreement. And really any questions that we have related to Bourne data, we reach out to Paula. And in addition, we have Paula and Jillian, who of course I'm sure many of you know, if not all. Jillian is an epidemiologist with Bourne, and they represent Bourne on our FAO Reproductive Health Working Group. And it's been incredibly valuable to have this relationship with Paula and Jillian. They've really deepened our understanding and interpretation of Bourne data. And there's many examples. Just a few would be helping with writing what we call core indicators at our Epidemiologist Association. They've provided us with presentations on how data is collected at Bourne, and they've created report templates for the Bourne information system that can be shared with other epidemiologists. So again, that's really just a few examples of our partnership. So then lastly, before I get into our demo, I'd just like to emphasize how important Bourne Ontario data is for public health, especially for information on healthy pregnancies, which are really not available to us from any other source. So Bourne really fills a data gap and is the most timely and consistent source of reproductive health data for public health units. And again, I'm sure many of you may be familiar with other sources of reproductive health data in Ontario. So at Peel and really all public health units across Ontario, we have access to two other sources. One would be the vital statistics from Statistics Canada, and the other is CHI-DAD from CHI. And another, I think, important difference is we don't receive data directly from these organizations. This data comes from these organizations to the Ontario Ministry of Health and then to the public health units. And so with our vital statistics, we found it's definitely less timely than Bourne data. The release of new years of data is not predictable, and there's very little data about the birthing parent. And then with our CHI-DAD data, similarly, not as timely as Bourne data. The release is not as predictable. And I think really importantly, we have no data on home births or births from other locations within that source. We also have almost no data about the birthing parent, and then we have no linkage between the birthing parent and the infant And again, this is referring to the cut of data that public health units receive from these sources. So there's some pretty significant limitations with the other sources. Okay, so then that's really just some information about our history and engagement. And now just to share some of our public-facing products. So we have a website, peelregion.ca/health status data, where we share these products, and we'll provide the link in the chat, and we also have a QR code. So we offer a variety of products. So we have long form reports. We just got a picture of one of our latest reports there. And then we have interactive reports. So this is something new for us, maybe in the last 2 to 3 years. Our team has really spent a lot of time creating these interactive reports, and they're done with Power BI. And then lastly, we have a mapping tool, which is done in ArcGIS, which is our public health data zone information tool, which is also a great tool. I won't have time to get into it today, but it can be viewed also on the website. Great. So we have 2 interactive reports with born data, which we've named Health in Pregnancy and Labor and Birth. So again, this is the URL and our QR code. So I'll just do a quick demo of these reports before I hand it over to Gabriella. And I just want to recognize the author of these reports. So I think she's here. Suzanne Fontana is a health analyst on our team. So she's not only analyzed all of the born data at Peel, but also created these interactive reports in Power BI. So thanks so much, Suzanne. All right, so just bear with me. I'm just going to switch over to my web browser. Great, and maybe I can just get a thumbs up if everyone can see the browser. Yeah, okay, great. Thank you so much. So I will continue. So this is our Peel Region website. This is live. You can see, it's not just Peel Public Health. We have many services, the recycling changes. But this webpage is our health status data site for Peel Public Health. And so, as I mentioned, we have a link to our long form reports, our health reports. We also have a link to our Peel Health Data Zone information tool. And then we have our interactive reports, which are all listed under these different topic areas. And so our reports with born data fall under reproductive and infant health. So you click here, then you'll see we have these accordions, so we can pop out health during pregnancy and labor and birth. And so our health during pregnancy report has about 8 indicators with information about substance use in pregnancy, folic acid use, prenatal class attendance, and maternal mental health concerns. And then we also have our labor and birth report, which has information about birth location, labor induction, parity, type of birth attendant, and type of birth. Right, so I've already launched. If we were to click here, I can just launch that. It'll launch into our health during pregnancy report. So we have a number of topics here, or tabs across the top. And then we have our key messages, which is just usually 3 key messages, looking at the indicator compared to Ontario, looking at a trend across time, and then if we have any kind of cross tabulations with sociodemographic data, we'll have a key message about that. And so we usually show kind of 2 visuals per page. So we're looking right now at self-reported smoking at time of birth for Peel in Ontario from calendar year 2013 up until 2023. So we're working now on updating this for 2024 as well. And then our second visual for born data, we usually show it by age group and by parity. So just coming back up to the top here. And so each of these tabs might be designed a little bit differently for how the user can interact with the data. So in this case, we have different buttons here to select different indicators related to tobacco use. So in this graph here, like I mentioned, we're showing smoking at time of birth. So we have a key message that 1% of pregnant Peel residents were smokers at the time of birth, and this proportion was lower compared to Ontario, which was 4%. And so if our users kind of just hover over the data here, I hope this is showing up on the screen, but we have a little tooltip here that will show you the data points. So in Ontario in 2023, 3.6% of pregnant residents were smokers at time of birth. We also have the number, and then you can compare that to Ontario, which is about 1%. And then we also have the ability for our users to right-click on our visuals, and they can see the data as a table. Great. We can just come back to the report. So then just looking at our next graph, which shows smoking at time of birth by age group and by parity. So we can kind of show all the age groups across all years. And again, just hovering over the data point. And then the user has the ability to toggle on and off different age groups if you wanted to kind of drill down on one of the age groups. You have that option, and same with our parity data. So looking at first births compared to repeat births. And again, just being able to toggle on and off. And then we always include some notes under our table, as well as the source of the data. Okay, and then just being aware of time, I'll just quickly kind of wrap up here so I can send it over to Gabriella. So as I mentioned, we might have different options for users to kind of toggle between indicators. So in this case, with more of the substance use, they can click on this drop down here and switch between alcohol use, cannabis use, and drug use. So again, we have our key messages, we have our data trend across years, and then we have our kind of crosstabs visual. Okay, and then just to wrap this up, so we also, with each product, like to provide some data sources and notes. So for each indicator, you can select here and it will dynamically update the notes to be about that indicator. So we provide some information about born, as well as when we access the data for this report, some information about the population, so who's included, who's not, and then again, some information specific to that variable. And of course, acknowledgement of born data, and we like to just provide the user for a suggested citation. Great. So that's a very quick overview of our health and pregnancy report. So I'm just going to send it back to Gabriella, but I just really encourage everyone to check out our website. So just bear with me here. I will come back to our presentation. All right,
Thanks so
I think
much,
the floor.
Natalie. So I'm just going to bear with me, sorry everybody, while I skip ahead.
All right. So thank you so much, Natalie. So now we're going to switch gears and discuss some ways that public health uses born data internally, and specifically to support our family health division. So as Natalie introduced, Peel Public Health includes a family health division that focuses on healthy growth and development in the early years. And born data is sometimes used to support or inform family health's work to provide services that build a strong foundation for lifelong health and well-being. And so I'm going to speak to three main areas. So firstly, born data has been used internally to contextualize some performance measurement information from family health operations. Secondly, born data has been used by family health to inform communications with interest holders, such as in council reports and hospital rounds presentations. And then thirdly, born data has sometimes been used to inform program planning. So depending on the program and its goals, this can look differently. But for instance, family health conducts research reviews to inform nursing practice and public health guidance. And so born data has sometimes been used to understand the potential reach of changes to these guidelines. And then additionally, there have been some instances where born data has supported our understanding of local trends within Peel to identify areas that may benefit from additional access to services. And so in the next few slides, I'll expand on just one example for each of these three use cases. So in terms of internal dashboards, as I mentioned, born data can provide context sometimes for operational data. So for many years, Family Health has maintained records and in some instance dashboards of their operational data from service delivery. And while this has looked differently over time, this tracking of information is designed to monitor and improve service delivery. So one of these dashboards outlines key indicators from the Healthy Babies, Healthy Children program, which Natalie introduced, is also known as HBHC. So HBHC is a program that offers support to eligible families during pregnancy and in the early years. And so a standardized screening tool is completed following birth to determine follow-up for more in-depth assessment of who may benefit from additional supports, including home visits by public health nurses. And so the goal is that all births in Ontario receive an HBHC screen. Operational data from all stages of this process are tracked by Family Health, and so historically this has been through a dashboard. And while much of this dashboard data comes directly from HBHC interactions, born data can help contextualize the HBHC information. So for instance, comparing the number of HBHC screens that are completed against the number of live births by hospital can identify if hospitals are achieving the target of 90% of newborns being screened. And then additionally, certain specific HBHC screen items that are used to assess risk have similar elements in born. So for instance, born items such as C-section delivery, gestational diabetes, large for gestational age, and small for gestational age reflect similar HBHC screening items. And so born data for these items can help contextualize the HBHC screening results and ensure that the information is representative as well. So secondly, born data has been used in numerous presentations and reports, both internally and externally. So just speaking to one example, recently our Associate Medical Officer of Health presented a hospital rounds presentation for partners and interest holders at Trillium Health Partners and William Osler. And so throughout the presentation, various born data were referenced to describe population health trends in reproductive health in Peel. So for instance, the number of live births in 2024 showed an increase compared to previous years, as Natalie alluded to. And so this can demonstrate the growing demand for maternal and child health services in Peel. Additionally, rates of gestational diabetes and experiencing mental health concerns during pregnancy also emphasized the importance of maintaining continuity of care from primary care to community-based public health services to support mothers with these experiences. So that's just an example of born data being used in some program presentations and reports. And then lastly, born data alongside other sources has also occasionally been used to support program planning. So family health partners with community services that provide certain prenatal programs. And so born data has sometimes been used to support this work. So given the highly specific geographic data that we have access to through born, we're able to investigate geographic trends in certain reproductive outcomes, such as the number of births, and compare that with other demographic information and where services are geographically located. And so together, this information can provide insights into areas that may face additional barriers in accessing services. So similar analyses have been done for different services and at different points in time, but just speaking to one example, in 2023, our team analyzed the number of live births in Peel in 2020 by census tract. And this, alongside other sociodemographic information, was mapped, and geospatial analyses, so such as cluster analysis and outlier analysis, were performed to identify areas of focus with greater need for program services. And so coming out of that work, this information has informed discussions of how to improve access for future planning, including leveraging existing partnerships to enable greater access to infant feeding and prenatal education services. So as you can see, born data provides a lot of really meaningful information to Peel Public Health. And so we're really grateful for all the work that you do at Born to maintain and enhance this registry. But we also know that you're continually innovating and enhancing Born. And we also recognize the constraints on Born and hospitals in terms of these enhancements. So in terms of data quality initiatives, Peel's data would benefit from decreased missingness across some indicators, as well as enhanced documentation on data collection to complement the data dictionary. But we really wanted to speak to some unique opportunities that would support public health units to enhance our population health assessment and align with your vision to be an authoritative source of accurate, trusted, and timely information to monitor, evaluate, and plan for the best possible beginnings for lifelong health. And so I'm just going to speak to two examples for these opportunities for enhancement that are particularly relevant from a public health perspective. So access to Ontario comparison data in the Cube and access to additional sociodemographic data would enhance our understanding of local trends. So as Natalie explained, the Public Health Unit Analytic Reporting Tool, known as the Cube, allows us to look at custom cross-tabulations to conduct specific analyses for our needs. And so unlike the standard reports, the Cube does not currently include Ontario-level data, and so currently includes data only specific to our health unit, so in our case, Peel. But having access to Ontario data within the Cube would allow us to include a more meaningful comparison for some of the detailed indicators we extract from the Cube. And so including a provincial comparison can help contextualize the Peel data and support our interpretation. So in the reports that Natalie shared through that kind of those interactive reports, you'll notice some indicators have Ontario comparison information and some don't, as those indicators we don't have access to the Ontario information for. So for instance, our reporting of the proportion of pregnancies delivered by cesarean sections and vaginal births by age group comes from the Cube. So you'll see this if you dig around in those reports that Natalie shared, but in 2023, 22% of Peel pregnancies among those aged 20 to 24 were delivered by cesarean section. But to better understand if this might be considered high or low, it would be valuable to have a comparison against Ontario. And so having access to aggregated Ontario data in the cube would allow us to better contextualize PEEL indicators to understand differences in trends and identify where additional supports may be needed. So the next opportunity for enhancement I wanted to speak to was around access to sociodemographic data. So I understand that Bourne is in the process of developing a provincial framework for collecting, governing, and using sociodemographic data in perinatal care, and has conducted a survey to assess the current state of collection. So we're really excited to see where that work lands and how it may inform our access and use of sociodemographic data in public health. And we just wanted to speak from our public health perspective as to why this information is so valuable. So in population health assessment, the ability to stratify indicators by certain sociodemographic variables can help inform our understanding of health inequities and target support to certain populations where applicable. So currently, certain sociodemographic variables are collected through Bourne, but they're not currently available to us through the Bourne information system. And so if access to sociodemographic item data in the aggregated form, such as parental region of birth, maternal marital status, racial group coming from prenatal screening information, and father's age, were expanded. So if access were expanded to enable public health units access to this data, this would allow us to further understand maternal and child health and disparities in PEEL. And so that first row in blue at the top there are some examples of some sociodemographic data that is available through Bourne, but not currently available to us through the Bourne information system. And then we know that there are many constraints on what is possible to collect and share, but we've also heard some interest from partners on having access to additional stratifications. So some items that aren't currently included in Bourne, but might be opportunities for consideration as this work moves forward. So information on maternal immigrant status, maternal ethnicity, and language spoken, among a few others, are some constructs of interest. So those are highlighted in blue there in that second row. And so we also just wanted to speak to a recent development at PEEL. So we've recently implemented sociodemographic data collection within our electronic medical records for certain public health services. So this work has involved developing a standard set of sociodemographic data constructs to collect, and many of these constructs align with items that would be of interest from Bourne. So having consistency across data in the constructs available is really valuable. So the standard set of constructs being collected by PEEL include preferred language, born in Canada or arrived in Canada, ethnic origin, racial identity, disability status, housing situation, and gender identity. And this work to collect this information and develop the standard set of constructs was guided by a set of key principles that were developed through collaboration and best practice guidelines. And then just noting that some additional constructs requiring further collaboration are also being considered, and so that list may evolve. And so we just wanted to share this work as it would be valuable to be able to understand reproductive health trends across some of the same constructs to understand disparities and better serve our community. So that wraps up the content for our presentation. So I'll just take a moment to summarize some key takeaways from what we discussed. So PEEL has the second highest number of births in an Ontario public health unit. And Bourne data provides the most timely and consistent source of reproductive health data for public health units and supports our work in alignment with the Ontario Public Health Standards. Bourne data is used externally in PEEL's public-facing reports, so including those items that Natalie demonstrated. And Bourne data is used internally in many ways, including to support dashboards, presentations, and program planning. And then lastly, access to Ontario comparison data and sociodemographic data in the cube would further enhance Bourne for public health units. So thank you so much. I'm going to stop sharing, and I think we'll have some time for a Q&A.
Thank you so much, Natalie and Gabriella, for your presentation. It was so informative and a really great, clear, practical example of what data to impact really means. We do have some time for a question and answer period. I see that there's some questions in the Q&A box now, but I also want to remind everyone that to feel free to raise your hand and we can unmute you if you prefer to ask a question using your mic as well. So the first question I'm seeing here is, if you had to pick one Peel data to action example that best shows the value of Born for planning or service delivery, which story would you highlight and what changed as a result?
Did you want to take that one, Gabriella, or do you want me to jump in?
I'm happy to go ahead. I'm sure
Okay, you go ahead.
there are many examples, and I'm sure I'm not actually even aware of all of them. Just recognizing some family health colleagues might have many examples that we might not be aware of. But I think one that was really interesting to me was kind of the third example that I shared around geographic analyses comparing where births are happening, trends and some sociodemographic information, and then where services are physically located, and how Born data has informed kind of going forward from that work for planning where services may be located in the future, and in the absence of sometimes being able to change where services are located, how better can we reach folks? And so that can be like across a lot of family health services. And so really a broad application of that, a simple amount of data having kind of wide ranging impacts.
Great, thanks so much, Gabriella. Natalie, I see you're unmuted. Did you want to add to that?
I was just going to add more onto what Gabriella was saying in terms of our team is not even aware of all the examples that Family Health is using the data for. And particularly, we have our research planning and policy team as well. I see some of you here who also are Born data users who have access to the standard reports. And our Family Health division has a very big emphasis on using data. So I know that they're also using it as well.
Great, thanks so much. And is there anything in your workflow that would make it easier to translate insights into action?
I think, and Gabriella, maybe again, you want to speak to the enhancements. I guess as we're seeing like different systems evolve, data systems. So maybe in the future there might be enhancements like with the technology around the Born information system, which we've experienced with some of our other systems maybe a little bit as well, like things moving to clouds. I know that the system also moved to the cloud, but even the interface for our analysts, maybe like a little bit of modernization and what's possible. Just thinking about it from our health analyst side and being a user myself of the biz as well. So maybe there's opportunities for a bit of modernization, but again, we completely understand how resource intensive that is.
Great, thanks, Natalie. Just check the question and answer box to see if there's any more questions here. There's just a comment here that I'll read out from Dana, and it's, I like your use of the term interest groups. Thanks for demonstrating that as it relates to awareness of language choice. Any other questions from anyone today? Okay. Okay, well, if there's no further questions, we can give everyone some time back into your lunch hour. And I see a question here from Dana Marie. Yeah, go ahead, Dina. I've enabled your mic.
There we go. Thank you. Sorry about that. This was a really, really great presentation. Thank you so much. I was just wondering, I put it in the Q&A, but you probably, I don't know if you saw it, it might be taking a while to get through. I know sometimes Q&As are funny. I know Born's data collection has expanded in some recent years, and I know actually just lately we've expanded with our RSV data. And I'm just wondering how you see some enhancements fitting into your reporting product roadmap, if you do have anything, because I know that some of the data, I think in some of the reporting products are from like 2023, and I wasn't sure, like for example, we're coming up with an RSV BI tool ourselves shortly. So I was wondering how that might help, because I can totally see how this would be usable for seeing like tracking immunizations in the Peel region.
Mm-hmm. Yeah, and I've heard about that report coming. I should just mention too, the reason we apply a bit of a data lag, Public Health Ontario, and I don't know if Jillian, if you're there, I can't remember off the top of my head, but maybe through Born's and AFAO's work together, when public health units use the data, we work off a calendar year, not a fiscal year, and we usually apply a 6-month lag to the data just to give time for all those data quality initiatives to happen. So that's why we're using that 6-month lag. So we are working on our 2024 data analysis right now, but that's why our products currently have 2023 data. And we are planning on adding an infections in pregnancy tab to that health and pregnancy report, which is great. And then in terms of immunizations, super valuable data. We unfortunately, like for me and Gabrielle and Greg, we can't speak as directly because our team, we have a whole separate team at Peel for surveillance and immunizations. Greg, I don't know if you wanted to add anything about that, but I'm sure they would be very interested in that data.
Yeah, nothing really specific to add other than just, I agree with you, Natalie, like definitely would be of interest. Yeah, something we can definitely consider in finding the right spot, because I'm sure some of our interest holders throughout the rest of the health system would be interested in that as well. So definitely something we can consider.
Great. I see more questions here. I think they were slightly delayed. Peter is asking, you noted that a significant share of Peel residents deliver outside of the region. How does that affect planning, and how does Born help you see your population more completely than other sources?
Yeah, this one might be better for our family health colleagues. But it does affect, I'm just thinking of things around like entry to service to our programs, some of the relationships that we have between public health and the hospitals. Right. So when we have a large amount of births coming from other hospitals, we may not have those same connections. And how does it help us see your, yeah. So, again, just I think some of the things we mentioned with maybe some of the limitations of the other sources, like being able to have access to that, makes a difference. I don't know, again, like Greg and Gabrielle, if you wanted to add anything there, I don't know if that was the best answer.
Yeah, I mean, I agree, Natalie. I feel like this one, maybe we can chat with some of our family health colleagues afterwards and share a response back. I think the main thing is that, like to Peter's point in the question, it does help us fully see the picture of births among Peel residents, which is certainly, I think, an important component of our population health assessment work, rather than focusing just on births that happen to occur in Peel hospitals. Yeah, so I think it's an important and strength of the system itself. And then maybe we can just respond back after the meeting with some more direct connections to how it impacts planning.
Great, that sounds great. Well, thank you. Thank you again. I think that concludes all the questions that I'm seeing in the question and answer box today. Before we wrap up, I did want to note that we do have a survey to gather your feedback on today's Lunch and Learn, and we'll put that link into the chat. As well, we also, for those from Peel Region who are attending, we also have a link if you'd like to subscribe to Bourne's newsletter and stay up to date. You can feel free to subscribe there. And thanks in advance thanks to our presenters for taking the time to provide your presentation today. They've also provided a link or an email address here. If you have any questions related to the content of today's presentation, please feel free to follow up with our presenters through the email address here. And on the next few slides, Gabriella and Natalie and Greg shared some resources with us, so we encourage you to check those out. And thanks again, everyone, for taking the time to join us today.
Thanks so much.